My name is Robert Newton and I'm Professor of Exercise Medicine at Edith Cowan University. My presentation today is on exercise as medicine for men with prostate cancer, and I'd like to thank the Prostate Cancer Foundation of Australia for this opportunity. So exercise medicine is the physical assessment and prescription of exercise specifically for the prevention or treatment of injury or illness. Exercise is a medicine because it drives endogenous medicine. It actually causes our body to change, both chemically and physically. And this is through changes in hormones and smaller molecules which are called cytokines that signal and produce changes within the body. Within all the systems of the body. But there's also considerable immune system responses as well, driven by exercise. And these are very positive changes. And this is, again, a reason why exercise is a medicine. But beyond this, it also drives direct structural adaptation and repair. Certain types of exercise will increase muscle mass, for example, increase the strength and mass of bones. It will reduce fat mass. And so quite considerable structural changes which are important and, to be fair, cannot really be driven through exogenous medicine, in other words pharmaceuticals or drugs. Exercise also changes blood perfusion and drives vascular adaptations which we'll see are very important in terms of reducing risk of cancer but also in treating cancer as well. And we now know that exercise as a medicine facilitates other therapies and reduces the side effects of cancer therapies. So just some background as to the main modes of exercise. The first one is aerobic exercise, which is very sustained exercise involving large muscle groups activated repeatedly over an extended period. And this includes walking, jogging, running, cycling, rowing, swimming, these types of exercises. There's two subtypes, moderate intensity continuous training or high intensity intermittent or interval training, which involves the repetition of high intensity bouts mixed with lower intensity recovery intervals. The important thing is that aerobic exercise, whether it is MICT or HIIT, must be moderate to vigorous for benefit. And so when we're talking about a rating of perceived exertion here, going from very light activity up to absolute maximum at 10, really for health benefit, you need to be exercising somewhere in this 4 to 8 range here, somewhere between moderate and vigorous. So moderate is you're breathing heavily, and you can hold short conversations and it's still somewhat comfortable, but it's becoming noticeably more challenging. To vigorous, where it's borderline uncomfortable, you're short of breath and you can only speak in very short sentences. So that's where we need to be, in this green to yellow area, to get the best benefit. The other main mode of exercise is termed resistance training or strength training. And this consists of performing exercises against resistance where the number of repetitions that can be completed is limited to 6 to 12. If you can do more than 12 repetitions, then the resistance is too low and needs to be increased. Now, you don't have to do these sets of exercises to absolute failure where you cannot lift the weight, but you can stop 1 to 2 repetitions before what's called neuromuscular failure, and the evidence shows that you still get considerable benefit. There's different types of contractions or sub-types within resistance training. Concentric is the pushing out movement. Eccentric is the lowering movement. But also ballistic, where the movements can be performed quite explosively and rapidly. And each of these have different influences on the body systems and different training adaptations and benefits. So this is a very nice figure from Kerry Cornier's group, published right back in 2007 actually, but I believe it really summarises exercise and physical activity across the cancer control framework. This is the point of diagnosis here, and exercise physical activity does have a role here, particularly in the prevention of the getting cancer in the first place. Being physically active, avoiding being sedentary, provides a considerable reduction in risk of developing certain cancers, in particular prostate, breast, and colon cancers. But at this point of diagnosis here, then again exercise comes in as a very important treatment or therapy. And it is right across from this point of diagnosis right through to the end stages of life here that it has a role. Certainly in pre-treatment or what is called pre-habilitation, use of exercise medicine to prepare the patient for their subsequent treatment. So we'll show you some recent research from our team preparing men for their radical prostatectomy, the removal of their prostate cancer. And it's really about increasing the resilience of the patient to get them ready for whether it be cancer surgery or chemotherapy or radiation therapy. Then we apply exercise medicine during treatment here for several reasons, particularly the reduction of treatment side effects. We know that if the patient exercises during their androgen deprivation therapy, hormone therapy for prostate cancer, chemotherapy or radiation therapy, they'll experience much lower levels of treatment side effects. But also, there's good evidence that exercise during treatment will increase treatment effectiveness. And it appears to enhance chemotherapy, but also radiation therapy effectiveness. But then, once the patient has completed therapy, treatment, or completed their surgery, exercise is now used as a rehabilitative therapy. And this is to enhance recovery, improve the return of function and structure, and help them to overcome the various side effects that they will have experienced. But also, it's very important at this phase here to continue exercising throughout life, in particular to reduce the risk of the cancer recurrence. And this is obviously a huge fear for anyone who's had a cancer experience, that will this disease come back? And again, solid evidence to indicate that being physically active, in particular doing targeted exercise, will actually reduce the risk of recurrence. Now, as we get to the stage where the cancer can no longer be treated, this is really about palliative phase here, and this may last several years or a matter of weeks or months. And again, exercise is being applied here in particular to try and maintain quality of life. But also we're seeing exercise very important here, as emerging evidence indicates that it may actually push out survival here, actually increase survival. And again, very important application of exercise as a medicine. Now, we've talked back and forth here between physical activity and exercise as a medicine. Physical activity is any bodily movement that uses energy. So it's playing golf, it's walking, it's doing sport, those types of activities. But exercise is more targeted. It is a subgroup of physical activity which is planned and has a specific purpose to enhance health, prevent or treat disease. And so that's the sort of differentiation between physical activity versus exercise. And the predominant, most of this presentation, and certainly the work of our team, is more about exercise medicine rather than purely physical activity. So next we'll just have a look at some of the very large epidemiological data around exercise and cancer. And this is just one paper published in 2016. And it was an analysis of prospective cohort studies, post-diagnosis, how much exercise they did, whether they were physically active and did a particular threshold of exercise, and cancer-specific mortality. And you'll see that most of these studies were published in breast cancer, with some in colorectal, and then also in prostate cancer here. But what we see here is what's called this plot here of the effect estimate. And what it basically indicates is that any of these lines, these squares, which are on 1, means that there's no benefit of exercise in terms of cancer-specific mortality. If it's a effect greater than 1, then it's actually detrimental. In other words, exercise reduces your survival. But if it is less than 1, it is actually reducing cancer-specific mortality. So what we see across these studies, first off, is that no study is actually giving an estimate of risk above 1. There's no evidence whatsoever in the now hundreds of exercise trials in cancer and also clinical experience to indicate that exercise exacerbates cancer. And this is important because for many decades it was thought that exercise might make the cancer worse, that it might make it spread, that it might make it grow more quickly. And there's absolutely no evidence for that whatsoever. In fact, the overwhelming evidence is that exercise actually slows cancer progression. It reduces the risk of metastases. And so across all of these studies here, the overall of the 26 studies, the overall reduction was 37% in risk of cancer-specific mortality. I mean, this is quite an astounding outcome that, across these so many thousands of patients here, overall there's something like 38,000 patients, and a 37% reduction in risk, which is quite astounding. Now, specific to prostate cancer, I'll just draw your attention to just one of many studies, but this is an interesting one here by Kenfield and colleagues, published in 2011. And what they showed is that men that did 3 or more hours per week of vigorous activity had a 49% lower risk of all-cause mortality and a 61% lower risk of prostate cancer-specific death. Now, this is an important study because what it demonstrated was that not only does exercise reduce risk of dying, of your cancer specifically, but the intensity appears to be very, very important. Higher intensity, more vigorous activity gives a much greater protection here. That's important. So then, the question is, well, how does this occur? How is it that exercise, which is relatively inexpensive, freely available as well, how can it be so effective at increasing survival of cancer patients when put against drugs which cost tens of millions or billions of dollars to develop and then can be quite expensive in terms of the healthcare system? But we see that exercise is producing similar benefits in terms of survival, but without, of course, any side effects. Now, very important to mention here that exercise does not cure cancer. And so the message is not to give up your androgen deprivation therapy or refuse to the offer of chemotherapy and just exercise. That's not the message. Exercise is a powerful assistive or adjunct therapy to the mainstream therapies of surgery, chemotherapy, radiation therapy. So coming back to my original point is that how is it that exercise actually increases survival? So this is a paper we published in 2016 from our team in Nature Reviews Urology. And we proposed 10 mechanisms by which exercise actually alters the tumor biology. It actually changes the internal environment within the prostate cancer, or any cancer, but we're talking about prostate cancer today, to actually suppress its rate of growth and metastasis. And through various mechanisms, and this includes improved immune function, changes in hormone receptors as well and hormone levels, reduced systemic inflammation and oxidative stress, changes in tumor vascularization, changes in gene expression and epigenetic modulation, changes again within the nucleus of the cell in terms of telomere alterations as well, and then modulation of circulating factors within the in the bloodstream, such as insulin, growth factors, and sex steroid hormones. So I hope this is getting the understanding across that exercise is actually a medicine, but it changes through producing endogenous, internal derived medicines, and that's why exercise has no side effects. All it is doing is switching off and on internal signaling, chemical and physical structural messages within the body that actually suppress tumor progression. So this is a very nice summary here from Lee Jones's group, published in 2017. And it explains the situation if we are sedentary here then we have a different, what is termed systemic milieu. In other words, the biochemical environment within the body. We have high metabolic hormones such as insulin, glucose, and IGF-1, and sex steroids such as estrogen. We have high inflammation, and we have autonomic dysfunction. This produces a positive environment within the tumour. So within the tumour microenvironment here, being sedentary actually promotes tumour progression and metastasis. When we do acute exercise though, our respiration goes up, cardiac output, etc. And this increases tumour perfusion, the blood flow through the tumour. It increases oxygen delivery. Catecholamines, such as adrenaline, noradrenaline, increase. Hypoxia goes down, and what is called shear stress. So this is the actual stress or forces on the blood vessels goes up. These are highly suppressive of tumour development, again changing the environment within the tumour. When we do repeated bouts of exercise, in other words, as we train over weeks and months and become more trained and fit, again, this results in considerable changes in physiological adaptation here. And the result is that all of these sedentary situation here conditions are reversed. Metabolic hormones come down, sex steroids, inflammation is reduced, and autonomic dysfunction is reduced. And what this does is it actually has a highly negative or suppressive effect on the tumour within the actual tumour. And so this is a nice summary of what's occurring here. So let's go on and just have a look at a few experimental studies here, just to illustrate certain aspects of this highly effective medicine, which is exercise in terms of cancer. The first one is clear demonstration that exercise suppresses cell growth. Now, in this study, they took 10 healthy male subjects and they had them complete 60 minutes of stationary cycling. They drew blood pre and post this acute bout of exercise, and then what they did is they poured the serum over prostate cancer cell lines. And what they found was in 9 of 10 individuals, they saw significant suppression of cancer cell growth. When they put the serum of the 10 patients together, 10 individuals, they were healthy, they weren't patients. When they put it together and poured it over the cell lines, they saw a 31% inhibition. And so here it's expressed here. This is at 96 hours here, the rate of growth of these cancer cells, prostate cancer cells, which are in vitro. In other words, they're sitting in a tissue bath. And this is an inert control substance here, and this is the blood serum at rest before they actually exercise. You see, there's no effect, none at all. So what we know is that at rest, these suppressive chemicals within our bloodstream are not present. But post-exercise, we see this 31% reduction in the rate of growth. So clearly, when we exercise, we produce these substances which are suppressive for prostate cancer cell growth. Now, this is a very interesting study here, and it was looking at the exercise-induced immunotherapy, if you like. And this was, in fact, an animal study. They took rodents and they injected them, in this case, with human melanoma cells, and then looked at the rate of growth, volume, and number of tumours. And melanoma in the rodent develops in their lungs. And they took these animals, and these were genetically identical animals. And they were in the same laboratory. They each had their own individual cages, and they were fed the identical diet. However, of the 12 animals, 6 were given an exercise wheel. And if you put an exercise wheel in a rodent's cage, it'll hop on it and run and run and run. And when they sacrificed the animals and looked at tumour volume, they saw a huge difference between the control animals that didn't have access to an exercise wheel and those that did. And also the number of lung tumours was much lower as well. And what they saw was improved immune function, increased immune cell surveillance, activation, and also infiltration of these cells. Because when they actually looked at the lungs of these animals, they saw that the exercise animals had much lower volume. These dark areas are actual melanoma tumour compared to the control animals, but also they saw that the lungs of the exercising animals were absolutely filled with what are called natural killer cells. And natural killer cells are cells that all of us have in our body, and they are highly effective at destroying, identifying and destroying cancerous cells. And so this is the mechanism, a very clear mechanism here, by which exercise enhances the immune response, increases the number of immune cells, drives them into the actual tumor and activates them, causing considerable suppression of cancer cell growth. So this really brings us to how does exercise enhance treatment efficacy? So efficacy of anti-cancer treatment depends on successful targeting. In other words, delivery of the drug or radiation to the tumor or residual tumor cells. Now the tumor must be sensitive though to the cytotoxic impact of the treatment. So when we have the tumor here and we exercise, we have both acutely and chronically with training, we have considerable changes within the actual tumor. Acutely and chronically, there is more oxygen delivered. And this is beneficial because tumors have generally low blood flow and poor oxygenation. They're said to be hypoxic. And that's fine for the tumor cells because tumor cells can survive and proliferate quite well in a low oxygen environment, whereas healthy cells do not proliferate as well. But exercise increases blood flow and increases delivery of oxygen. But we also see with exercise increased number of immune cells. They are more active and have better surveillance, but also through the exercise they are driven into the tumor more effectively. But also this process allows better delivery of drugs into the tumor and also enhancement of radiation therapy as well. So let's talk a little about this radiation therapy effect because of course radiation therapy is very, very commonly applied for men with prostate cancer. Now radiation therapy works by irradiating the tumor, and the radiation causes direct damage to the DNA of the cells. Now the cells, tumor cells tend to be dividing much more rapidly. When a cell is dividing, it is more vulnerable to damage of its DNA, which will make the cell unviable, and it will then die. So that's why when radiation oncologists irradiate the prostate, they have a preferential kill of the cancer cells rather than the normal cells. But there's also another effect called the oxygen enhancement effect. And what happens here is the irradiation also causes water ionization destabilization. This leads to formation of reactive radical species. These react with neighboring molecules to yield reactive oxygen species, ROS. The hydroxyl radical is the most cytotoxic. It is very, very damaging to the DNA. However, this formation of this DNA radical here, interaction here with the ROS, is readily reversible. In the presence of oxygen, the DNA damage can be stabilized, and then you don't get the subsequent cancer cell death. Now, this is a problem because, as we've mentioned, cancers generally have low blood flow and poor oxygenation. So any mechanism by which we can increase the oxygen within the tumor when you're undergoing radiation therapy will result in a greater kill of cancer cells. So, now, acute exercise increases blood perfusion of tumors. Now, tumor arterioles under exercise, it's interesting, they don't actually vasoconstrict. Most tissues within the body, when we start to exercise, they actually constrict and shut down blood flow so that the blood can be diverted to the working muscles. So what happens here is you get greatly increased blood pressure and blood flow through the tumor. If you exercise chronically, so in other words, you become trained, then this normalizes blood vessel structure within the tumors. Tumors, because they grow so rapidly, have a very disorganized microvascular structure. But exercise appears to normalize it, again helping to increase blood flow, oxygenation, and delivery of more immune cells, and also delivery of any chemotherapy or other drugs which are given to the patient. So the message here is cancer patients must exercise chronically at all stages of cancer treatment. And cancer patients are recommended to exercise immediately prior to radiation therapy. So just before you go into the radiation therapy, a short amount of exercise, it may only be 10 to 20 minutes, to increase your blood pressure and perfusion and oxygenation of your tumour so that the radiation therapy is more effective. Now, it appears that exercise also enhances chemotherapy. It's still a little bit speculative around the mechanisms. It does enhance distribution of the drug throughout the body, so this would make it more effective in the circulating tumour cells in particular being exposed to the chemotherapy and destroying them. It increases the immunological recognition of dying tumour cells. The exercise does this, and this is important again. Induction of memory immune cells could add to future protection against recurrent nodules and also circulating tumour cells. But what is definitely known is that there is a reduction in side effects of chemotherapy if the patient exercises. And this is important because it means less side effects, means less dose reduction, means more chemotherapy delivered to the patient, means more likelihood of destroying the cancer and becoming cancer-free. Again, we are recommending chronically exercising throughout your course of chemotherapy, but also exercising immediately before or after receiving the infusion. So we have acute and chronic effects of exercise, and every exercise bout matters. Basically, we see here, each time we exercise is an exercise bout. Here, we increase our myokines and catecholamines. These are very important substances within the blood which have anti-tumour effects here. And that spike in exercise factors reduces tumour growth and cancer risk. But over time, as we train and we have repeat bouts here, then this is important as well. And the take-home message here is it is better to perform short bouts of exercise pretty much every day so that you're dosing the body with these anti-cancer drugs, these anti-cancer medicines that are produced by exercise. And it's just like taking Panadol for a headache. You don't take the whole bottle in the morning and hope that it keeps your headache away for the week. Well, you'd end up in emergency with paracetamol poisoning. But obviously you take a couple of, if you have a headache or back pain, you take a couple of painkillers, each day across the week to control it. It's the same with exercise. It needs to be dosed regularly, preferably every single day. Now, with chronic training, though, what we see is also dramatic long-term changes. Insulin goes down, sex hormones and inflammatory markers are reduced. And again, this is highly beneficial. It decreases the risk factors, although it does have to be accompanied by weight loss, fat loss and muscle gain, reduced tumour growth and cancer risks again. So these changes are nicely summarised in terms of what is called the therapeutic window. Because what happens is exercise shifts the treatment efficacy to the left. So what that means is that here we have treatment dose and here we have effective concentration within the blood to actually have a therapeutic effect. So what happens is with exercise, this curve shifts to the left. Treatment efficacy increases so that for any given dose here, you have much better effectiveness. But it also shifts the treatment toxicity to the right because it suppresses side effects. And so overall, what we have is the therapeutic window here is greatly increased, meaning much better effectiveness of treatment. So moving on and talking about some more of some research studies. This is a study from our own group here, and this is a very recent paper published in Surgical Oncology this year, and it was led by one of our PhD students, Rebecca Wilson, now Dr. Rebecca Wilson, from our team in collaboration with Tom Shannon. Dr. Tom Shannon's a urologist here in Perth. And what this involved was a very pragmatic intervention with men with prostate cancer that were overweight or obese, and they were preparing for a robot-assisted radical prostatectomy, in other words, having their prostate removed. And it was to address the issue of increasing proportion of men due for prostatectomy being overweight or obese, and this very much compromises the surgical procedure and also exacerbates post-surgical complications. So this is a program developed by Dr. Shannon and his team to try and rapidly lose body fat leading up to surgery. And it involved 90 minutes or more per day of exercise, combined with a very low caloric diet, around 3,000 to 4,000 kilojoules. And this was a very pragmatic study. It was conducted in Dr. Shannon's clinic with his patients. And some very, very important outcomes from this. We see here in terms of the body composition changes, significant and meaningful reduction in total body weight of 7.3 kilograms. 5 kilograms of that was actually loss of fat mass. Percent body fat also decreased by 3.1%, which is, all of these highly significant. The only issue, though, was that they also lost 2.4 kilograms of lean mass muscle, which is problematic. And whilst resistance training was recommended to the patients, it wasn't a requirement. And so this is a problem, and we know that resistance training should stop this loss of muscle mass, which is quite concerning. But overall, good loss of body fat, which is important, and considerable improvements. In particular, we see here a reduction in systolic blood pressure and diastolic blood pressure, which was also quite encouraging. Now, the second study conducted by Dr. Wilson involved an actual trial of weight loss for obese prostate cancer patients receiving androgen deprivation therapy. And androgen deprivation therapy, whilst highly effective for slowing the progression of the prostate cancer, does have several toxicities, one of which is muscle loss and considerable fat gain. And so we implemented a 12-week intervention of 300 minutes per week of exercise, plus also this included several sessions of resistance training to try and prevent this loss of muscle that occurs when you have dietary restriction. Energy deficit, we aimed for around 2100 to 4200 kilojoules per day. And this paper has been published in Medicine, Science in Sports and Exercise. Very encouraging in terms of total body loss. There was most of the patients, these are the actual individual patients in this study. You can see that most lost up to almost 10 kilos of body mass here, and this was a fairly good loss of fat mass here as well. This patient number 3, for example, lost 7 kilos of fat in only 12 weeks of intervention. Good loss here also of trunk fat mass and visceral fat mass, the very dangerous fat around the abdomen. In terms of lean mass, it was a little bit mixed here. We had about half of the patients actually gain lean mass, but half actually lost lean mass. And the same with appendicular skeletal muscle mass as well. So overall, there was no change in muscle mass for these patients, but a bit of a mixed response there, and it's probably related to how much they actually adhere to the resistance training program. But very, very important if you are trying to lose fat mass, whether it be for preparation for surgery or just overall to improve health, you must also complete at least 2 or more resistance training sessions each week to avoid this muscle loss, which has considerable implications, in particular for people with cancer. So this was another study here, and this was in men with prostate cancer receiving androgen deprivation therapy. And one of the great issues is that ADT, one of the side effects is the loss of bone mass, and this is a real concern. And so in this study, it was a quite unique study. We published it in 2018 in Medicine, Science and Sport and Exercise. And this was the first study ever in the world to demonstrate that bone loss could be prevented by a very targeted exercise prescription. And so the men here, as you can see, performed high impact exercise here. So this is fairly advanced, and these men, I just want to mention that these men underwent several months of resistance training first to get them strong enough and resilient enough to be able to do this impact loading. But the impact loading here has been demonstrated in other studies to be really effective for bone health. Now, we had 3 groups. The first group was a delayed or controlled group here, and then we had a group that did aerobic plus resistance training. And then this third group did the combination of resistance and impact loading, this plyometric type exercise. What's interesting is that there was no difference between the aerobic resistance and the control group here. Now, this was surprising because normally if we gave this resistance training program to, say, menopausal women, it would actually stop bone loss. But in men on ADT, it's not the right medicine. It's not sufficient. They have to do the combination of resistance and impact loading. So this was the first study ever to show these highly specific effects in men on androgen deprivation therapy. And I think the take-home message here is that exercise is not a single medicine. The type, the mode of exercise, and also the dosage has enormous differences in terms of the systems and how it actually affects them. Now, what was also interesting in this study, from this same study here, is that we saw a significant difference in terms of skeletal muscle development here. And particularly of the arms and legs, the muscle mass here, a significant difference between the impact resistance and the aerobic resistance. Now, what we hypothesize here is that there is an interference effect. What that means is that we know in elite athletes that aerobic exercise interferes with the growth of muscle and development of strength. Now, for most normal, healthy people not on hormone therapy, this is not normally a problem. But it appears that in men with prostate cancer, that aerobic exercise actually interferes with the benefits derived from strength training. And so it's important then to make sure that if skeletal muscle loss, sarcopenia, and declines in physical strength and function is the main problem, then probably the aerobic exercise needs to be minimized. And the focus really needs to be on strength training to build up muscle, build up strength, and build up function. So this interference effect in men receiving ADT appears to be much more significant. So let's change our attention now to men with more advanced prostate cancer. So these are men with stage 4 cancer. It's metastasized away from the primary site in the prostate, and it's now evident predominantly in the skeleton. And at the time, these men, when we first proposed this study, that'd be almost a decade ago, men were advised not to exercise if they had bone metastatic disease because of the fear of spontaneous fracture. But our clinician colleagues advised us that these patients were doing very poorly. They were declining rapidly, losing physical function, quality of life. Can we exercise them safely? And so we launched a study with a very special design, which we called M3EP, for multimodal exercise. And in this, what we did is base it on the scan, the bone scan for the individual patient. If they had certain metastatic sites, then we would adjust the resistance and aerobic training to avoid loading those sites of weakness. And we wanted to implement this to see if we could exercise men safely and if they'd actually respond when they were at this very advanced stage of prostate cancer. Well, the first thing is, yes, they can exercise. They completed an average of 32 out of a possible 36 sessions, 89% attendance. There was no exercise-related adverse events or skeletal fractures, so it was safe. They could exercise at a fairly high intensity as well, 12.7 on a 6 to 20 point scale. They perceived to be highly tolerable, 5.5 on a 0 to 7 scale. No change in pain and no bone pain assessed by the EFFACT bone pain scale here. So the take home from this is that yes, they tolerate it, it is safe, and they will do it. The next thing is, can they actually improve in terms of their physical function? Absolutely. We saw that these men significantly increased their strength relative to the control group, but also they exhibited significant improvement in their self-reported physical function here as well, which is also a very important outcome. However, this was a study where we avoided loading the bone. Now, there has been animal studies which have demonstrated that if you put cancer cells into the bones of animals and then you provide stress to those bones, it actually suppresses the development of the tumor. This is just one study, there's many others, but here this was an animal study where they put human breast cancer cells into the tibia, so it's a lower leg bone here, and then they tracked them over 6 weeks to see what happened. And they divided the animals into two groups, those that received loading to the bones versus those that were unloaded, and effectively exercise versus sedentary animals. And what we see here is that the loaded animals here, at 6 weeks, 100% still had intact tibias, whereas only around 30% of the unloaded. Now, if we look at tumour growth here, we see that the unloaded, we have 100% of the animals are tumor bearing, where it's less than 20% in those animals which were loaded. You can see the difference here in terms of the exercising animals here versus the animals that weren't given access to exercise. We have extensive breakdown of the bone here. So what it appears is that mechanical loading dramatically reduced the osteolysis and tumour formation and increased tibia cancellous mass due to trabecular thickening. In other words, the exercise appears to cause signalling within the bone, suppressing the growth of the tumour and maintaining bone integrity. So on the basis of this, we then launched a study in men with prostate cancer to determine if very controlled loading to the actual site of the metastatic lesions here, so this is prostate cancer which has metastasized to the spine, whether that could be done safely and whether it be tolerated and whether it might actually suppress the tumour progression. And this was the study, and this is the protocol paper which we published in BMJ Open. We're still analysing the results here, but certainly the results were that it is safe, it is tolerable, and using very controlled isometric training, so isometric contractions or static contractions of the spinal muscles, which we called SIT, combined with our M3EP program, we saw that there was no exacerbation of bone pain and certainly no fractures occurring there. So it is safe, it can be done. We're still waiting on the results of those studies to analyse that to see what the actual benefit is in terms of suppressing tumour progression. So this leads us to our current largest study which we're conducting, and this is called the Interval Gap 4 study. It's funded by Movember for $10 million. It's an international trial. We're recruiting some 866 patients around the world. We currently are in 8 countries with 20 sites. It's in Europe, Australia, China, North America, and the important aspect of this study is it is the first study in prostate cancer to prospectively determine in a randomized controlled trial whether exercise actually increases overall survival. So we have, as I presented earlier, excellent evidence retrospectively that people who are more active actually survive longer and their cancer-specific survival is improved. But we don't know if it is a reverse causality. In other words, because the patient feels better, they do more exercise and they live longer, not because of the exercise, just because they're doing better overall. So we need a randomized controlled study such as this to determine conclusively if exercise increases survival. So median survival is around 35 months for men at this stage of disease, and we've powered the study to see if this can be pushed out to 44.6 months. We've got some secondary outcomes there of time to disease progression, first symptomatic skeletal related event, etc., progress of pain, degree of pain, but we're also looking at several biomarkers of inflammation, metabolism and androgens, and also physical and emotional quality of life. The supervised arm is receiving exercise programming. It's supervised, it's a highly sophisticated program, stepping down to self-managed, involving moderate to vigorous aerobic and structured resistance exercise, whereas the self-directed exercise arm is receiving exercise recommendations and psychosocial support. Now, that study is ongoing, but it's very, very exciting. We have approximately 120 patients in trial at the moment. Again, our target is 866, so it is progressing quite well. And I hope in the coming year or so, we'll be able to present you with the actual results from that study. I can report, though, that the patients are enjoying the exercise, it's well tolerated, and we have no serious adverse events. So, last year, our team co-authored the Exercise and Sports Science Australia position statement on exercise medicine in cancer management. It was published in 2019 in the Journal of Science and Medicine in Sport, and this paper can be downloaded from this website. Now, we published the first position statement in the world back in 2009, and of course over 10 years there's been an enormous amount of research in exercise medicine for cancer, and the field has advanced markedly. Our recommendation in this 2019 statement is that we have to move to a much more tailored exercise prescription, assessing the patient, determining and prioritising their health issues, identifying patient capacity and intervention suitability, and then designing the exercise prescription. We are moving away from a generic recommendation of physical activity or exercise, a generic recommendation of exercise, to be much more specific to patient needs. This exercise prescription will vary by mode and actual exercise dosage, and then frequent reassessment and modification of that exercise prescription. In terms of priority, we need to address those issues causing the greatest morbidity and mortality first, combining that with patient goals, access to qualified exercise professionals and finance, capability to pay. And then the next priority is treatment enhancement, where the exercise can actually improve chemotherapy, radiation therapy. And then lastly, the lowest priority, while still important, is general health and fitness. But we have to address those health issues such as cardiovascular disease or sarcopenia or osteoporosis, which are causing the greatest morbidity and mortality risk first. So the foundation exercise prescription guidelines are that it should be in the main multimodal, combining aerobic and resistance exercise, but emphasis according to priority. Keeping in mind our research showing that aerobic exercise may actually interfere with the adaptations occurring through resistance training. It needs to be moderate to high intensity. Low intensity exercise will not drive the exercise medicine required. Frequency and duration needs to be most days, spread the dosage over the week as I've mentioned previously, and try to accumulate as much exercise medicine over the week as possible. It needs to progress to maintain relative intensity. In other words, as you get stronger and fitter, then the absolute load needs to go up, but the relative load, that means keeping the relative load the same. It needs to be periodized. This means varying the exercise across the week, month, and also around particular events, such as chemotherapy. It needs auto-regulation, meaning it's patient-driven. On days in which the patient feels particularly unwell, then we reduce the intensity and volume. But on days when they feel a little bit better, then's the time to increase the quality in particular of the exercise, with perhaps higher intensity resistance and aerobic exercise. So aerobic exercise, a general recommendation, emphasising the cardiorespiratory system. It's either moderate intensity continuous or high intensity intermittent training, as we discussed at the start of the presentation. Intensity really needs to be up around 65 to 85% of the patient's maximum heart rate. Minimum about 20 minutes. However, you can spread it across the day if the patient is particularly low functioning or has excessive fatigue. So you might do 10 minutes in the morning, middle of the day, and then in the afternoon. Overall, you want to accumulate 75 to 150 minutes of vigorous to moderate exercise each week, but for fat loss, you really need 300 minutes or more per week to actually reduce fat mass. A resistance exercise should combine dynamic, concentric and eccentric exercise. However, isometric or static muscle contractions may be required to work around patients with bone metastatic disease. It needs to be relatively heavy loads, 6 to 12 RM, but stopping 1 to 2 repetitions short of failure. You need to allow at least 48 hours recovery for any given muscle group. You need to use large muscle groups in functional movements such as squatting, chest press, deadlift. These are large muscle groups because they produce the most surges in these endogenous exercise medicines. Minimum of 2 sessions per week. Ideally, it would be 3 to 4 sessions per week, but then you would have to go to what's called a split program. Higher volume load, sets by reps by load, if the goal is to maintain or increase muscle mass, what is termed muscle hypertrophy, and to target the muscle groups specifically impacted by any particular treatments. Now, many patients will have acute or chronic cancer-related concerns which need to be targeted specifically. We list them all in our paper here, but just a couple of examples. If the patient has cachexia, so this is rapid weight loss, they need resistance training, potentially using eccentric muscle contractions. It might be advisable to limit aerobic exercise and also give nutritional support around protein, energy and creatine monohydrate supplementation. For bone loss, we need a highly specific resistance training and this impact loading, as we saw, with potential nutritional support through calcium and vitamin D supplementation. Our research and others shows that if the patient has issues around obesity and increased cardiovascular risk, then they need high volume aerobic training. You must do resistance training as well to prevent muscle loss, and nutritional support around caloric restriction. If there are other chronic diseases present, then this may be the focus. For example, cardiovascular disease is very prominent, particularly in men who are overweight, obese, or are on androgen deprivation therapy. And so this will be the main target rather than the cancer. Reducing body fat, increasing cardiorespiratory efficiency, normalizing blood lipid and glucose profile, lowering blood pressure, nutrition and anti-inflammatory diet such as the Mediterranean diet, ameliorating treatment side effects. For example, many of these patients will be on statins. The exercise will be effective for reducing side effects. Now, depending on treatment-related side effects as well as other patient considerations, it is possible that the signs and symptoms and side effects associated with the patient's chronic disease or risk of chronic disease may supersede cancer as a priority of the exercise prescription. Now, the setting, supervision, and how this interacts with patient risks and goals. So the patient might range from post-treatment, apparently healthy, moderate risk with relative contraindications, or they might be palliative or have quite high risk. That affects what setting and supervision is appropriate. For very low-risk patients, the park or home, community centre or fitness centre might be appropriate. But for high-risk patients, they really need to be in a dedicated exercise clinic or a hospital-based clinic. Now, this affects the supervision. For low risk, it might be self-managed or a lifestyle instructor or a fitness professional or an allied health professional. But for patients at higher risk or with relative contraindications, they really need an accredited exercise physiologist or clinical exercise physiologist or an allied health professional such as a physiotherapist who has undergone additional exercise physiology training. If they are at very high risk within a hospital or an exercise clinic, then really they need an accredited exercise physiologist who has specialty oncology training. So what is an accredited exercise physiologist? Well, these are minimum 4-year university trained with extensive clinical experience. They are registered with the Australian Health Professionals Association as well as being recognised by Medicare. Now, referral to the appropriate allied health professional is critical, particularly for patients with more advanced disease or if their cancer is causing other comorbidities such as cardiovascular disease or type 2 diabetes, osteoporosis or sarcopenia. But the accredited exercise physiologist is the most appropriate allied health professional for the prevention and management of chronic disease, exercise medicine assessment and prescription. They are accredited by our professional body, which is Exercise and Sports Science Australia, registered under Medicare. Increasingly, they have postgraduate exercise oncology experience and training. Now, you can find an accredited exercise physiologist on this website here, and you can specify your postcode and distance away. Designation as an accredited exercise physiologist, AEP, but you can also enter at the specialty of cancer to find someone who has special training and experience in exercise medicine, assessment and prescription for people with cancer. So I would like to thank you for your time and attention. I would particularly like to thank the Prostate Cancer Foundation of Australia providing this opportunity for me to present, and any more information that you may require, please feel free to contact me at my email address there or go to our website exercisemedicine.org.au. Thank you.